it together. That's the purpose also of Shavuos. And I will now share my. Are you there?
Yeah.
Good. I think you're there. Tell me if you are able to see. Wait a second. Got it?
Yep.
Yep.
Okay, good. I am. I guess I could do this in a different mode. Let me see. Wait a second. Maybe yes, maybe no. Slideshow. Okay, there we go. There we go. Okay, good. So I'm just going to do a tiny little bit of review before we get into the fundamentals for this week. Last week, I took it a little bit easier, and we talked about sanctity of life as a very important ethical principle. And, you know, I will kind of introduce again the topic of Jewish medical ethics by talking a little bit about what deontological formalist theories are in ethics. So deontological formalist theories are really defined by a set of rules or principles by which we make ethical decisions, in this case, medical ethical decisions, but you could generalize it. This is really to be, looked at in opposition to utilitarian principles, which really try to maximize good for the maximum number of people. Deontological principles are what we use in medicine. We don't like utilitarianism. That'll be the subject of the third talk when we talk about medicine under Nazi dictatorship and medicine as a tool for politics. So utilitarianism is very useful in rules of driving and perhaps in jurisprudence in some areas in the state of California, but it's not particularly useful in medicine. And so we like formalist theories that give us rules, however they come, whether they come from God or the Bible or Western civilization or whatever. And in Judaism, we look at deontological theories, deontological principles that are based on halakha. And I gave you the Chabad perspective on halakha last week. I'll do it again because I kind of like it. It's completely stolen. I didn't think of it or read it. Halakha being that halacha, Shulchan Aruch, Torah, Talmud, Rishonim, Achronim, Posekim. It's a guide. It's the Constitution. There's no person who's such a righteous tzaddik that can follow every single rule in the Shulchan Aruch. And, you just have to accept what you can do and you can't do. And you can take some opposition to some of the rules of the Constitution. But in terms of making a decision, an ethical decision, it's very helpful to look at 2,500 or 3,000 years of theory as well as practice, and how does the rule and how is pertinent information relevant to the case in using Jewish law. And I remind you again that these are the elemental approaches to the process of trying to make an ethical decision using halakha. You use writings, Torah, of course, the best, and then Talmud, particularly early Mishnah, and then Gemara, and then writers, the first writers, the Rishonim from the Talmudic period, the later writers, the Achronim, like Maimonides, like Rashi, like Nachmanides, and so on. And then in more recent times, in the last few hundred years, Posekim, these are very wise individuals who are presented with an ethical problem and then write a dissertation on the ethical problem as it pertains to Jewish law. And of course, their opinions don't have the status of law, but they are opinions that are useful in guiding us. And so we'll skip through some of this and remind you again that there are at least 4 primary ethical principles, and there's a 5th one that we can argue about. We'll talk a little bit about today and leave it on the table. And these are the 4 or 5 primary ethical principles from which one then can go on to try to struggle with an answer for a difficult ethical question. Last week, we talked about sanctity of life. And the reason that I brought it up first is it's the one that's brought up the least by our students. So when I ask students to please name for me ethical principles, just like they would name for me the pathophysiology of congestive heart failure or the pathophysiology of inflammatory bowel disease as we understand it today, they always come up with autonomy, because American culture worships at the altar of autonomy. Different cultures prioritize it differently. They often come up with justice. They almost never mention truth-telling. That's not big with the young generation. Non-maleficence is drilled into them from the beginning. We'll probably talk a little bit about that today as well. But what they never mention to a student is sanctity of life. And when I talked about this with Rabbi Nanas when we were preparing this, she said, well, that doesn't make sense. Why is that so? And I said, well, I don't have proof. I only have conjecture. And that is, if we were studying medical ethics before World War I, we would say that the doctor's number one principle is to save a life, and that life is precious regardless of its form. And we talked about that last week, even in the setting of abortion. But World War I and the last 100 years changed that, because we see that actually human life is quite cheap. And in Western civilization, millions of people were killed. Outside of Western civilization, we really don't even have a handle on the number of people that were killed wantonly for political or philosophical purposes, for genocide, for tribal purposes. And as you know, you could be walking to your car in any neighborhood at Glazer campus or in Pacific Palisades or Brentwood, and somebody will walk up to you, ask you for your car keys, take your car keys and shoot you, and they wouldn't think twice about it. And so today, sanctity of life does not rank high in people's thinking because they confront the opposite all the time, death. And so, although historically life is precious, and in Judeo-Christian ethics, life is precious, it's something we have to remind people of. And that's why we talked about the lady with the potential Down syndrome child. Now let's skip through that because we already talked about that. And now we're going to spend some time talking about autonomy and its limits and its complexities. And you'll begin to see, I'll give away the answer to the quiz question. What constitutes an ethical dilemma? It's when these 4 principles or maybe 5 principles conflict. And so when they are not coherent, then you've got a problem. And of course, in real life, it happens quite often that ethical problems conflict. So this is a real person. I don't need to invent any cases for you. I got a whole bunch of them. And this, after 30 years of practicing medicine, you get a lot of cases here. So this lady was a 90-year-old. I already identified her gender, but could be any gender. 90-year-old with a history of aggressive lymphoma, a cancer of the immune system. It had been treated 17 years before at the relatively youthful age of 73. With full dose chemotherapy, treated as if she were 30. She achieved complete remission. She did fine for 17 years. And then I was called by the family that she had a rapidly enlarging abdominal mass, originally painless, but then it became painful. And I made a house call, which I do once in a while if the traffic isn't too bad. And during COVID, that was pretty easy, actually. Sure enough, this lady had a big mass in the abdomen. And the patient was in agreement to be treated, although, her capacity was a little limited. She already had some cognitive decline. And so we treated her, but we didn't treat her intensively because she was frail. And we gave her a combination of chemotherapy, immunotherapy as an outpatient after a biopsy confirmed lymphoma. And 9 months after she got into another remission, it came back. And now she had lymph nodes all over the place. And now her dementia was a little bit worse. and the children were divided in terms of what to do vis-a-vis her therapy. Now, I don't know if we'll come to an answer with this, but this is the background, and you will hopefully unmute yourself at some point and we'll talk about some questions. Now, last week we said that many times ethical dilemmas are not so much philosophical dilemmas, but they may be dilemmas of facts, okay? And that's very, very often the case in the intensive care unit, where the younger doctors want to withdraw care for a patient because they say the patient has no likelihood of survival. And then, I say, well, let's not talk about the ethics just yet, but tell me what references you have in terms of survival, and then tell me how you define futility. Turns out we did a study of hematology patients in the ICU, and about 30 to 40% were alive 6 months later if you kept them on the ventilator. Now, is 30% futile or is 15% futile? There you begin to get into a philosophical argument, but at least let's talk about the facts. So the facts here with this case are recurrent lymphoma, inability to deliver intensive therapy, a short remission, and very limited access to other things, with a likelihood of achieving another remission probably in the realm of less than 10% or 15%. So those are the facts, and that's the backdrop. Now, let's go on to frame the ethical issue. The ethical issue is that we cannot deliver cytotoxic therapy, chemotherapy, without obtaining informed consent. That is an American take on autonomy. But to be fair, every culture has enshrined the choice, patient choice. Last week, we talked that in halakha, both in the Torah and then later in the Talmud, one is required to seek out therapy for disease, and a doctor has some role in being a healer, although ultimately, Ani Adonai Rofecha, I am the Lord who heals you. So ultimately, God is the one who heals, but you are required to seek out care. And I quoted that very funny Talmudic line from the Sanhedrin book that he who goes to a city where there are no physicians is a fool, and you shouldn't be locating yourself in a town where there's no medical care. So that implies that even the ancients among our people said you do need to seek medical care, but I'll provide you some references that enshrine choice as having some role in how you receive care. Now, informed consent is legally defined in American jurisprudence. And I have to be very careful because I see Marshall is on the line here, so I don't want to step into some area where he is, but I think he will agree that every state of the union, in some degree or another, requires informed consent to treat a patient. You sign it when you walk into a clinic. You sign it without knowing it when you come into the hospital that you have given consent to receive treatment. I don't think you pay attention to it. I certainly didn't when I was a patient, just coming out of cardiac arrest, but I'm sure I signed the thing at some point or another. But it's also ethically required because, again, throughout all of our cultures, from really a little child already begins to demonstrate his or her wishes to be respected. From the age of 6 months, when you try to serve a kid a teaspoon of peas and the kid flicks the peas away from you, that's demonstrating a certain degree of autonomy. The big question that is not solved by American jurisprudence, and we'll try to get into a little bit, is decision-making by surrogates. We assume that surrogates have the best interest of the patient at heart. That is a very faulty assumption. We had a patient in the early days of AIDS when I was a a student and then an intern who was in the intensive care unit receiving all manner of support that was deemed futile with the odds of long-term survival less than 10%, but the family insisted on all manner of support. This was before it was even known that AIDS was related to HIV. It was just really about that time, 84 or 85. And then suddenly the family came in and said, you know, we've had a decision, we've discussed it, and we want the patient taken off the ventilator. Well, in those days, we had a lawyer who ran our ethics consult group, and he wanted to explore this. And it turned out that there were financial reasons that were driving it. The patient was being kept alive because there was a line that had to be sold of what he was producing. And as soon as there were buyers, then the family could let the patient go. So, you know, I see Karen is shaking her head and nodding. I mean, you know, this is not crazy stuff. Surrogates make decisions for the surrogate. And sometimes it's not nefarious. Sometimes it's that the surrogate can't part with the loved one, or the surrogate has a history with the loved one and wants to part with the loved one. So the parameters of the surrogate are very difficult. And another element in the process of looking at facts is trying to discern what the surrogate wants. The most difficult is this case that I provided, where there are 4 children and there are 2 opinions with a split. And all are legitimate surrogates. One had the designated durable power of attorney for health care and kept kind of demonstrating that. But my role as a physician was to actually try to get them to come together so that 10 years later, somebody wouldn't say, well, yeah, you had the durable power of attorney for healthcare, but you really didn't represent mom very well. And I resent you for that. I mean, at some point, the patient is not the only patient, but the family also becomes the patient. So the concept of autonomy breaks down into 4 questions. For what do we respect autonomy? Is it for the thought of the patient, the action of the physician, or both? By whom do we respect autonomy? Well, ideally, it would be universally applied. You want to be respected for your own self-determination, and likewise, a patient wants to be respected for his or her self-determination. And autonomy is there to protect against the constraints of others, paternalism. If a person, however, is cognitively impaired, the constraints of others may be considered beneficent. And that, by the way, beneficence, I don't even know if we discuss it in this talk at all. Beneficence is considered a good but paternalistic action. Can anybody think of a law on the books that preserves and protects beneficence against your autonomous wish? Anybody ever heard of the Good Samaritan Law? Okay, so if one of you on the phone call drops dead, notwithstanding that you might be wearing some badge that says, do not resuscitate me, if somebody in the community jumps on your chest and does chest compressions and breaks your ribs, you will be protected as the care provider, because the law enshrines that element of beneficence and paternalism when we cannot really determine, even if you're wearing a sign on your chest, do not resuscitate. If you're not a professional and you're the nice guy who happens to see this and doesn't read the sign or doesn't understand what the sign means, you will be protected. Now, the Christianity, particularly Catholicism, is very big on beneficence, but you won't hear this very much in Judaism, because beneficence is in the eye of the beholder. So for whom is the action beneficial? And there are very few universal rules. There are some who baptize individuals, particularly Holocaust survivors, after their death. The Mormons have done this, okay? Because they believe that they are saving the soul of the Jewish person that didn't have the luck to be baptized. um, the law doesn't respect that for good reason. That's something that really could have been determined in life as an autonomous choice, and there is not universal agreement that that action is beneficial or favorable. There are other elements of beneficence out there, but in general, the law and Judaism too protects us from the benign intent of others when you could have said yes or no. And what are the limitations of autonomy? The limitations of autonomy are harm to others. The classic example being you don't yell fire in a crowded hall when there is no fire because you can harm others. Another example is, and this one is going to come up in this talk, suicide. Do you have the autonomous right to commit suicide? Of course, in Judaism, you don't. In some legal structures, you don't, because it's considered a harmful act to others. And between those two extremes, there will be many things in between. So let's go through this. The ethical issues that are related to the autonomy principle are obvious. Informed consent. We'll talk next week about the use of data from immoral experimentation. We alluded to it last week. You can't really present data, however compelling that might be, from experimentation in which there was no consent, because the impact for the ethical community is too great. And that if you were ever to do that, if you were ever to publish such a thing, you would actually be condoning the method by which you got the answer. So the end does not justify the means here, and we don't allow data obtained without consent to be presented. There are also issues regarding disclosure and comprehension. Now, if you have somebody that is mentally impaired, there's a competence issue that you might need some standards of disclosure, and you might need to have documentation that the person is really capable of giving informed consent. Now, there are some situations in which there will not be complete informed consent. In a randomized controlled trial, it is stated from the beginning that there'll be non-disclosure, that you might get randomized to treatment X versus treatment Y, and neither you nor the physician will know. You will be double blind. Here are the potential side effects of treatment X and treatment Y, but you know a priori that there will be no disclosure in the course of the study. So there is consent, and you do have the right to make an autonomous decision whether you're going to participate in that trial or not, but you will not know exactly which arm you're going to get into. And that does not violate the principle of autonomy. Now, here are some guidance from Jewish texts that again might be useful in answering our problem with the 90-year-old lady with relapsed lymphoma, now no longer responsive to the prior therapy. Some of these you've seen before from last week. Whoever sheds man's blood, by man his blood shall be shed, for in the image of God he made man. So certainly subjecting an individual to illegal experimentation, like we're going to talk about next week, that may lead to death, cannot be sanctioned. And experimentation, perhaps even experimentation that has a reasonable likelihood of leading to a fatal outcome, even if the person gave their consent and the principle of autonomy were upheld, wouldn't stand by this particular biblical Torah statement. From the writings, this one used to be on the chaplaincy building that UCLA sold, but I think it might still be on the building, but the building doesn't belong to the chaplaincy program and at UCLA anymore. Have we not all one Father? Hath not one God created us? Why do we deal treacherously every man against his brother by profaning the covenant of our fathers? Okay, that's something to think about in terms of mutual respect. We talked about Kant and the categorical imperative and the Jewish version of that: do not do unto others that which you would not do unto yourself. And since you would expect that you would be given permission to make decisions about your care? Would you not extend that same to somebody else? Now, this is a very interesting one from the second book of Kings. It was read not too many months ago. It was a Haftorah for one of the Parshiot. The setting is very, very interesting. There had been a plague in the Jewish city, and great famine was there as well. And a few of the people on the gates of the city are thinking, should we go into a neighboring city, a neighboring camp of our enemies and see what's going on there? This is a very classic setting for a decision. Should we stay in this plague-ridden city where there's famine, but our people and we feel safe? Or should we go to surgery, go into the adjoining city of our enemies to see whether they are suffering from famine and whether we might be able to get some food there? And they said one to another, why sit here until we die? If we say we will enter the city when the famine is in the city, we shall die there. But if we remain here, we die also. Therefore, let us fall into the camp of Aram. If they permit us to live, we shall live. And if they kill us, we shall die. And so you see, this can be generalized to obtaining consent for a risky procedure. You may have, I don't know, let me think, cardiac disease. And they are proposing for you to do some sort of open heart surgery, let's say, to do valve replacement. And there is a significant risk to the valve replacement. The valve replacement can produce stroke. The valve replacement might require anticoagulation for a lifetime, and the surgery itself is potentially life-threatening. And if you interpret this statement from the second book of Kings, the situation is really left up to you if you have adequate information, if you have adequate background, if you have adequate set of facts. If that surgery permits you to live, you will live. And if that surgery kills you, you have the choice to make the decision to die if you understand the facts well. And that's been the basis for a bunch of responsa literature in the last several hundred years regarding permission to refuse care. Last week we talked about the obligation to seek care, but there also is responsa literature by the rabbis, by poseks, regarding the refusal of care, which is also within your permission to a certain degree. The question is, what's the priority? On the left side, we see primary ethical principles, and on the right side, we see secondary ethical principles that may come into play. Here with this family, with this 90-year-old patient, I'm sure that beneficence and paternalism is operative. The problem is that the beneficence of one is different from the beneficence of the other, and they're all being paternalistic. And none of them probably is telling her the exact truth.
Excuse me, Gary.
Yeah, go ahead.
You're still on the first slide. I don't know if you're supposed to be or not, but
I'm not. I should have moved
so.
all the slides. Well, that's a very sad state of affairs.
Thank you.
I wish you had told me a long time ago, because then I was just giving you a lecture and we didn't have any slide presentation. But now do you see priorities?
Priorities, yes. Thank you very much.
Good. Well, you know, I want to go back. I wonder how I can go back to the last one. Doesn't seem to work. Now, can you see the ones before?
Yes. Yes.
Okay, good. So you can take a look at those for a second.
Thank you, Gary.
Thank you guys for telling me. Zoom, you know, at its best. So take a look at those.
I texted him a few minutes ago and he didn't read it.
Yeah, text I can't see because I can only see
Right.
your pictures and slides. And then here are the priorities. On the left side, we see the primary principles. I listed Sanctity of Life twice. And on the right side, the secondary principles that are operative in this very difficult case. And I won't go into the moral distinctions yet about euthanasia, because I want now somebody else to speak to speak up, and how you would approach the case of the week, the patient of the week. So we got 4 kids. They're making decisions for mom. You got one of them who wants to do everything medically feasible. You've got one who wants to do nothing. And you've got 2 that are struggling with both and trying to make peace. And the patient is not at full capacity.
Is there an advanced healthcare directive?
No, there, and by the way, that has no legal status. You should know that. We do not recognize them at UCLA, although we'll take them into consideration, but they have no legally binding status. But she has assigned a durable power of attorney for healthcare to the son who wants to do everything. Come on, this crowd can speak up, I'm sure. Oops, no, not that. Well, what do you do?
Is there any way you can know what she would have wanted to do for herself?
Right.
Well, that's helpful. Yes, and actually you cut to the chase very quickly. And because I knew her for 17 years and I knew her husband, I knew the family, I did have inkling into the limits on care that she would want. But I'm not a completely neutral party either, right? I always worry about that. I had a little bit more legitimacy, for example, than when one of our loved ones goes to an intensive care unit and you meet the resident or the fellow that never knew the person before, and they say, would you really want this person to be on a ventilator? You know, we think that this is the wrong thing to do and you should let the person go. I mean, that happens constantly. And I always say that the healthcare providers are not neutral parties. They're overworked. They define futility more liberally than others. They don't have a relationship with the patient. They certainly don't have a relationship with the family. So they don't act as a neutral party. And I don't for a moment say that I act as a neutral party either, but I think if you have a many-year relationship, you do have a little bit more credibility.
Gary, will you entertain questions now, or do you want us to
Go
wait?
for it. Yeah, just jump in.
So why did you say that you feel that the Advanced Healthcare Directive has no legal significance or power?
Because when it's been tested, it has no legal compelling power because it's not done in the situation at hand. That's another philosophical point that's brought up in halachic, Jewish medical ethics all the time, at hand. So when you fill out a directive as a healthy 65-year-old, but then as an 80-year-old with chronic illness, you have a stroke, that document that you produced when you were well and healthy really has very little relevance to your situation because you didn't anticipate the physical state that you would be in at 80.
But I don't agree with that because in the healthcare directive, the patient designates an agent to make that decision for him or her. And
that's the only thing that's legally useful. Yes. The
And
designation.
Their values and preferences.
and the probate code vests that designated agent with the power to make certain choices.
Right. But you notice the difference. It's not a subtle difference. It's a very overt difference. It designates a person who dynamically changes, as does the patient.
But the power that person has doesn't change.
Yeah.
No, that person is designated the surrogate. You're right. But there are other instruments that are in use that say at age 65, you signed it, I would never want to be on a ventilator. And then at 75, you get pneumonia and you're on a ventilator. That has no standing because you couldn't anticipate what your medical situation would be like when you were 65 or 25 or 35. The only thing that has standing is the designation of the surrogate. But here, we also are trying to make peace because the designated surrogate has siblings that oppose his thinking. So I think the better way that was brought up was to try to discuss with all of the parties what your long-term relationship as a doctor has been with that patient and what that patient's expressed sentiment was when he or she was cognitively intact.
Mhm.
And that is a little bit of paternalism, I guess, because it's guiding somebody. It's not being totally neutral. But again, we talked about this last week. We're not being paid to be totally neutral. We're not supposed to be a corpse with no emotion or expression. Again, looking at the Maimonides statement. Amy.
What do you think about talking to the family about what the mom had gone through with her own family when have there been any similar situations when
That's
they've
very
had
helpful because her husband had gone through similar things as well. That's very helpful. You're right. And the other thing is, I guess, being willing to talk to all the different parties, which is, of course, time consuming, and to talk to them separately.
Dr. Schiller, do you have a healthcare consultant group? In other words, who is dispassionate, but can come up with all the questions with the family and not getting into all the, shall we say, the emotional aspects of it?
Well, we have an ethics group. They are fairly tightly tied to our palliative care, but they do function somewhat separately. So there is an ethics committee, and we do call them, but they're also all strangers. So they would not have known anybody, not the patient and not the family, before this crisis.
But don't you also think that you, the way you're stating it, and I understand you're looking at this through a Jewish perspective, is that correct solely? This is not okay. So having said that, though, do we necessarily think if you have known that patient all along, there are doctors, however, that do come into these situations that have total, they don't know anything about the family or the patient. And so when he is the only person that, let's just say, that the family can speak with, hopefully he is speaking, but of course we're saying that there would be a Jewish doctor. Is that correct? Or
well, it happened that this was a Jewish ethical issue, and so fortunately we spoke the same language.
but supposing this doctor was not Jewish, so
Yes,
therefore
it was not.
Pardon?
I still think there is a balance between not doing harm, non-maleficence, the first thing on the left there, and we have to be a little more expansive about what that means. Autonomy and surrogacy, and sanctity of life, because we're talking about end of life. And so I think the principles apply, but the way they're prioritized might vary from culture to culture. The next one is the real big one, and that is euthanasia. Because taken to the extreme, many people feel that we have a right to be put to death. Active euthanasia, not passive. With this patient, we can justify withholding care for a few reasons. The facts are that any kind of therapy we give is expected to have short-term efficacy. By the way, the ultimate answer was we did try something else and it didn't work. So fact number one, very poor likelihood that something that I'll come up with is going to work. Number two, anything I come up with will be harmful because I'm a cancer doctor. And so our treatments are not typically benign. So there's a non-maleficence problem. And as I brought up with the designate, the surrogate who had the durable power of attorney for healthcare, she would have expressed limits on how far to go. And halakha expresses limits if somebody is really in a terminal state. In order to make peace with the one who was driving therapy versus the one who was not, and the two that were in the middle, it ultimately ended up that I was talking to rabbis around the planet, one in Australia and one in Canada and one in LA at all different kind of hours. But again, because we spoke the same language, we could advocate for passive euthanasia because none of our treatments really would have met the level required for healing. The troublesome one as a Jewish doctor is active euthanasia. That one for me is too far gone. And whatever your right is to decide when you want to die, I'm not sure that your right necessarily means I have obligation. So where your rights become my obligation, then I can withdraw, which, as you know, the state respects as well.
Are you saying euthanasia? When you say euthanasia, you're talking about withdrawal of life support?
No.
What are you talking about?
That's
You're talking about comfort care, what we call comfort care at UCLA, or what do you?
Well,
I don't know, because
know,
I don't think we do euthanasia. So when you mention that, they do that in like Canada. So when you say it,
well, no, this state allows that. Jerry Brown signed a law passed by the state.
That's not euthanasia. Well, it's a long story, but we don't call it euthanasia. We don't call it suicide in California. I know, but you can believe that's what it is. I don't know what I think about it, but I know a lot about it.
Well, I'll make it. I won't make it quite too complicated. I think drugs with the intent, given with the intent to hasten.
Prescribed. Got it.
Yes, that is very hard to dress up in any way other than what it is.
I was thinking
I know what my question though was, what is passive? I'm sorry, what is passive euthanasia?
Passive euthanasia means the withdrawal of care in somebody who's imminently dying.
Stopping dialysis.
It's not active. And I do agree with you, Amy, that there is this slippery slope I put on the slide, and you can't easily establish a wedge there when you are giving morphine for the dying patient. Many times I have asked this question. It doesn't land me in a very good place, but I've asked the question, if somebody has no pain and is already in a coma, then what is the purpose of the morphine drip? And if
They're going to die anyway.
If that's not active euthanasia, I don't know what you call it. But if you say that term, people get obviously quite angry. So,
Yeah, Dr. Schiller, I have a question though. With passive euthanasia, doesn't that defy the sanctity of life though? Because you can end up suffering more through that if it's that you stop the medication. You're
not suffering, but again, even in the halachas, we talked in the Talmudic story about the nailing of the roof that's keeping somebody who's a goses, who already is in the terminal stages and really exiting this world from exiting the world, and permitting that person to die. Sanctity of life may not even be an issue anymore. So if somebody is dying of widely metastatic malignancy, for example, it's very hard to make a case that there's any intervention that will save life. And yet, the interventions that we could come up with would certainly violate the other principles. Certainly, you couldn't call them non-maleficent. By the way, I go along with that, Amy, on the morphine drip that's being administered to somebody who's had multiple strokes and is no longer conscious or aware, because you can't dress that morphine up, as people do, as a benign or beneficent act, as a merciful act. The morphine is intended to hasten the person's death. It might be a merciful act for the family that has to deal with this. Okay, I get that, but you can't say that it's a merciful act for somebody who is already deeply in a coma. So what perception is there? We have nobody who's come back who told us that they perceived pain nonetheless, notwithstanding.
So do we do that? when somebody's
do that.
in a coma? Because
We
I know
do-
when people are struggling for air,
That's
they
different.
are more comfortable.
Again, that's a little bit of a different case. If
That's right.
somebody is struggling for air and is in the terminal stages and heading towards death, that's a merciful treatment. That morphine is to alleviate symptoms, and I can dress it up that way. But, you know, again, just between us and not to be advertised, we certainly have taken patients who are comatose and put them on morphine for the dying patient protocol.
You mean if they're in a suffering state
No.
of gasping for air?
No, we have.
Yeah, I wanted to take issue with yours, only with what you're saying, because I agreed with you at first when you said when the patient has already hit the stage where they are dying and they are no longer responsive, they are in the comatose state, there is no reason to continue with active morphine
Therapy, yeah.
So now you're saying, what are you giving them anything for if they are not suffering?
Good question. I can't answer it for you because I struggle with it, and I can't say that I never have signed on to that because, you know, I'm kind of averse to controversy. I don't like to every day be having an argument and fight with somebody, but I do ask the moral question. If somebody is comatose, if somebody is dying, then what is that other than active euthanasia? But it could get me into a lot of trouble if I say it really loud.
Sorry.
And I was going to say, I think it's just our discomfort with the process that we wish to hasten it along.
You don't need
Gary, could I come in with a question, please?
Please, or statement.
No, I don't do statements. I'm retired. I've never met anyone objective in the process of dealing with those who are dying. I don't think an objective person exists. Even the unknowing doctor from the outside who was called in already has a set of experiences, a set of ingrained training, whatever it is. So the search for the objective participant doesn't exist, at least from my perspective. Secondly, in philosophy and even in law, the argument for slippery slope is very weak. It's often disparaged in 1L courses when students just beginning the study of law raise slippery slope to a professor, and the professor will cruelly, bitterly, aggressively shoot them down because slippery slope has no real place in moral discussion because it's a projection of one's own inner convictions, desires, perspectives. And I would like to say as well that there is no such thing as Jewish medical ethics. There are Jewish medical ethicists, and they write brilliantly, and they explore tremendously important topics. But Jewish medical ethics is defined by the people who hold a particular system and call it or claim it to be Jewish. And one can hide behind that very easily. Jewish medical ethics says, fill in the blank. You're going to get a lot of different answers when you attempt to fill in the blank.
So what's the question?
The question is, do we recognize the fact that people have their own set of experiences and that they should have the right, without imposing anyone else's system or order of deontological or any other system, it is the individual confronting the mortality of a loved one or of their own mortality. They can take consultation, but their decisions are their decisions, not governed by slippery slope, not governed by structured ethical systems, but rather quite related to the moment at hand.
Okay, so that was a very, very long thing.
That's called emotionalism.
Somewhere embedded in that soliloquy was a question. I think I get it. And I will say the answer no. Because you have to make something somewhat objective out of this subjective experience. Otherwise, you have no framework in which to approach the next patient. And of course, there is no objectivity. And last week, I think I explained that, of course, Jewish medical ethics has too many adjectives. It's simply ethics. And then what's Jewish about it and what's medical about it is the way that our texts are used to approach the problem and to try to structure the problem. We didn't ever get to, and now we're kind of at the end, we didn't get to the this patient at hand if there was somebody who wanted to give intravenous fluids. Well, how can we interpret intravenous fluids? Doesn't that keep a person alive who might be dying? It's not a particularly maleficent act. It doesn't involve the risks of chemotherapy. It doesn't involve the risks of injury. It's a very passive thing. Where do you draw the line? And as a practitioner, you know, people on this phone call, other than the rabbis and the doctors, people on this phone call hopefully don't ever have to deal with this, or you will deal with it once or twice. But people who are taking care of dying patients all the time, as a theologian, chaplain, but not just a theologian, really somebody who's in chaplaincy, or somebody who is in a medical situation where a lot of people die, you know, you have to have some framework. Like I said last week, you don't approach congestive heart failure and to say, well, congestive heart failure in Rabbi David's is a little bit different from congestive heart failure in Mrs. Brody, because one is a man and one is a woman. And of course, those things are in play and those things are under discussion. But if you don't have a framework for approaching the problem, then you can't answer the basic question and shoot from your hip. Now, there was somebody who raised his hand there, I saw.
Bruce Larson.
Bruce,
It was
okay.
me.
Oh, yeah, hey, how are you?
Gary, I have a question to ask you. In Judaism, is there a theological or moral value to the act of suffering?
Not in the Christian sense.
Okay. What in the sense? What is the sense of Jews? Is it? Can you explain that? Elaborate.
I don't know if I can explain that, and I'll go back and I'm going to go and take a look at some texts. I'm going to see if there's any particular value to suffering, but it is not redemptive like it is in Christianity. In Christianity, there's an element of suffering that is redemptive, and as perceived by the Christians, their Lord Jesus Christ suffered for the sins of mankind and redeemed the suffering of others through his crucifixion. And
I'm well aware of that.
That's a concept that again informs beneficence, but is not a concept that's universal. So we will get to a little more. Well, I'll leave you with one more little statement from a great physician and writer with whom you can disagree. Okay, one who kills a treifa, which is not only used for something that's not kosher, but something that is potentially perishable. If the treifa can eat, drink, or walk in the street, is not punished in a human court. Every person is presumed to be fully viable. Hence, a killer is to be executed unless it is known for certain that the victim in this case was perhaps suffering, that the victim had suffered from an incurable and terminal condition that would have killed him had nothing else intervened. And so there is your permission, in a way, for passive euthanasia. But where do you draw the line? And fluids and food and blood tests and transfusions, all of those things might cross the line. I will not talk about the double effect principle this week, because next week I'm going to address Rabbi David's question when we talk about the slow progression of medical professionals who, without a structure, deontological structure, had no trouble convincing themselves that human experimentation was allowed, that mercy killing of mentally retarded kids was allowed, and really there was a slippery slope and there ultimately was no barrier. But it took place in stages. So we'll go historically from 1933 to 1945 and what was going on in this country, because there was stuff going on here as well. And you'll see that although slippery slope may be a problem in a philosophy class, at the bedside, it's a real issue because there are no natural limits. Okay, and almost at Havdalah, you got another 25 minutes. I wish everybody a wonderful end of Sukkot holiday. I hope it was meaningful. And Shavuos, there's my brain, Shavuos holiday. I'm not so many months away. And wish everybody health. Is there any last kind of question before we?
So just because I didn't come in last time, this is my second, your second and my first. And we are dealing with orthodoxy. Are we dealing with, in other words, when we speak of Judaism, because we have different gradations of Judaism, how are we to, just so we, if I object and I may not be coming in on the right department. So I want to make sure that we're.
Well, I think we're looking at writings. And so we're trying to look at the texts. And maybe that's and this way they will not have a political veneer.
But we are still dealing with different levels of Judaism. If we are not dealing with
interpretations, or different interpretations.
Different interpretations, but it's just that if we're going to deal with the orthodoxy, this could reach a totally different level of conversation.
Well, you'll still have to deal with the texts because people have been thinking about this for a long
time. For sure.
And for example, the Rambam was writing before there was a Shulchan Aruch. So Caro had not written yet what, how you purify your plates, milchik and fleischik, and has not yet written about the details of how you hang your mezuzah. So these things, a lot of these writings came before what you consider orthodoxy, but they are Jewish. So take it that way. Okay, everybody.
Thank you.
Thank you.
Good night.
Good night.
Thank you so much.
Thank you.
It's been amazing. Thank you.
Thanks for the good questions.
Thank you.
I'll go and try to look up some stuff too. Thanks.
Thanks a lot. Yeah.